All right. Good afternoon, everyone. My name is Dr. Iqbal. As an Iqbal, I am Assistant Professor Rheumatology with Thomas Rheumatology Group based in Charleston, West Virginia. I believe we have recently joined WVU, so we're also coming up to pace and joining the big league. Uh, Moving on, my topic of presentation today is psoriatic arthritis. I don't have any disclaimers as such to declare. Just a heads up, this presentation is mostly geared towards fellows. So if you think the information is a little bit overwhelming, I'm just going to skip to the basics so that it doesn't gets too much boring for the listeners. So, objective of the presentation today is to basically discuss about psoriatic arthritis as a whole, how the disease evolves, what's the clinical presentation, and how to diagnose and how to manage the disease essentially. Introducing psoriatic arthritis, it's an inflammatory musculoskeletal disease which is associated with psoriasis. Initially, back in the day, it used to be considered sort of a variant of rheumatoid arthritis, but with time they realized that this does not quite sit well with the typical presentation that is seen in patients with rheumatoid arthritis. And then for a short while, it was sort of lumped into seronegative disease. And then with time, they sort of realized that no, this is a separate disease entity altogether. So epidemiologically, incidence of the disease is 6 per 100,000 people. Prevalence is about 1 to 2 per 100 per 1,000 people in general population. Now, the interesting number here is 1 out of 5 patients with psoriasis will eventually end up developing psoriatic arthritis. So in your practice, I'm sure we're used to seeing patients with psoriasis. So I think it's a good number to keep an eye on, that 1 out of those 5 patients will eventually start having symptoms of arthritis. Patient to see if their presentation is osteoarthritis or there's more to it. And if there is something more to it, can you can you guys hear me? Because I just got a notification about poor signals. Okay, all right.
You're good
So
so far.
okay, so if you feel that there's something more to the presentation of arthritis, maybe it's worth referring to rheumatology for further evaluation. Uh, It has a significant genetic association. Uh, it has been seen to be affecting 27 to 50% of the people who have a family history of psoriasis. In fact, this is also one of the diagnostic criteria. If someone has a family history of psoriasis, it sort of counts towards the diagnosis. Uh, Genetic association, they have found out multiple diseases. The most common one to be on the lookout for is HLA-B27. Now, I know that normally HLA-B27 is usually associated with ankylosing spondylitis, but having this disease with association of or with involvement of lower back and spondyloarthropathy. Other diseases, other genes of concern are HLA-DR4, which is oftentimes associated with worse radiographic progression, and miscellaneous other genes, which we can find in the genome-wide association studies. Now, certain environmental factors also affect psoriatic arthritis. One thing is called Koebner's phenomenon, where basically you induce a skin trauma, or the patient reports a skin trauma, and that trauma, the site of trauma, eventually. Another phenomena which is called deep Koebner's phenomena, which is oftentimes reported in about 25% of the patients, where they say that they've had some sort of trauma, and that trauma led to symptoms of both psoriasis as well as inflammation hitting them together. Uh, Patients can also have subclinical trauma, mostly affecting the DIP joints, especially in patients who are in mechanical labor. And of course, obesity, smoking, streptococcal pharyngitis has been known to precipitate psoriasis. There is an association with stress as well. Stress can potentially uh, trigger flares in these patients. Now, histological findings, I know this slide is a little uh, busy, but I'll just narrow it down for the participants. So basically, when we're looking at psoriasis, we're looking at hyperkeratosis of the skin, which is the skin turnover increases. Okay, patients have those hyperkeratotic lesions, and then on biopsy we see parakeratosis, which is retention of the nuclei of the of the cells, especially the top layers. Usually, the nuclei sort of goes away in normal skin, and then the landmark of the pathology is neutrophil sandwiches between the parakeratotic layers. Essentially, what that means is you'll see lots of inflammatory cells between the layers of the skin on the biopsy. And that with that, and this is pathognomonic for psoriasis in these patients. So another busy slide, but as I said, this is mostly for the rheumatology fellows. But essentially, this is different modalities of our immune system, which our body sort of goes through, and this is essentially the upregulation of IL-23 and IL-17 system is what triggers the innate immune system to get activated and then cause psoriasis and psoriatic arthritis down the line. So, talking a little bit about pathophysiology, as I discussed earlier, it has a dysregulation of your immune system, both innate as well as acquired. Uh, an acquired immune system, it is the CD8 MHC1 T cell activation, especially triggered by IL-23 and 17 pathway. And this further triggers IL-23 stimulation, and then the cytokines IL-17, TNF, and all of those cytokines upregulation down the line, which causes psoriasis and arthritis. Now, coming to the psoriasis itself, um, in most patients in psoriatic arthritis, psoriasis proceeds by 8 to 10 years in about 6 to 7% of the patients. There's no particular pattern which is associated with psoriatic arthritis in itself. Any psoriasis can precipitate psoriatic arthritis down the line. What has been associated is the extent of body coverage. So we asked the patients about historical skin involvement as to what percentage of skin was involved, and depending on that, we see uh, we've seen that the association of arthritis goes up. Okay, whenever we're evaluating a patient with psoriasis, it's always a good idea to look at the hidden sites which are not commonly visible. For example, the scalp, perineum, between the gluteal folds, umbilicus, and behind the ears is a common site where psoriasis can be hiding, especially the scalp, where patients feel it's just dandruff, but if you look closely, you'll see the excoriations of which are similar to and scales which are similar to psoriasis. Now, arthritis is seen, um, it sort of proceeds in about only 33% of the patients early before psoriasis, but mostly it is seen with psoriasis. There are different types of arthritis, which has been postulated towards psoriatic arthritis, but the most common type is rheumatoid-like disease. In simple terms, patients would present with inflammatory arthropathy with findings of psoriasis. And to simplify, inflammatory arthropathy would be patients would report symptoms of tenderness in the hand joints, which could be PIP, DIP, MCP joints, along with symptoms of morning stiffness. They can report swelling of these certain joints and also report symptoms of dactylitis. Now, a small percentage of patients whose HLA-B27 is positive will also present with axial involvement, which is lower back pain with morning stiffness. Uh, so we have to be on the lookout for these for the presentation of arthritis in these patients to see if it's psoriatic arthritis or not. Clinical features, the most common presentation of symptoms seen in patients with psoriatic arthritis is nail changes. That is also in diagnostic criteria for psoriatic arthritis. And I'll go with further details about these clinical features as well. And then there's, of course, psoriatic lesions. Morning stiffness is very common in many patients. It depends on where the morning stiffness is. It's worth asking, is it involving lower back or is it involving the hands, knuckles? And then dactylitis, which we often call sausage finger. Ocular involvement like uveitis. Fatigue occurs in about 22% of the patients, and then the arthritis mutilans is basically where their DIP joints erode in about 5% of the patients. Now, skin findings are pretty interesting, and if you see a patient with psoriasis with significant skin involvement, that could potentially lead to further early evaluation of psoriatic arthritis. A patient can have pitting of the nails. They could have leukonychia, red macules on the nail bed, crumbling of the nails, and trichonychia as well. And then the patients can have nail bed psoriasis as well, which is the involvement of psoriasis within the nail bed, which can cause hyperkeratosis, splinter hemorrhages, salmon spots, and onycholysis, which is basically the nail bed sort of rises from the base. And that could also happen in patients who have psoriatic arthritis. Now, looking at psoriasis itself, we've all seen psoriasis in patients. As I mentioned, it's really important to look at the common sites where psoriasis hides, especially uh, the belly button. It can hide behind the ears itself and in the scalp hairline. So if you look closely, the patient would say they have dandruff or really mild lesions. But if you look closely, you'll be surprised how often we see psoriatic lesions, especially in men, because they don't tend to complain that much and do have psoriatic lesions. Okay. So types of psoriasis, the most common type of psoriasis is plaque psoriasis, which is sharp, demarcated, scaly, silvery lesions, oftentimes seen in the extensor surfaces, elbows, and knees. Then another type of psoriasis is inverse psoriasis, which often involves in the vaginal folds as well as below between the breast folds. And then there's guttate psoriasis, which can often be triggered by after the patient gets a vaccine, and it has small guttate punctate spots with silvery crusting on the top. Then there's erythrodermic psoriasis, which mostly looks like sunburn or like a burn lesion. And this is a pretty severe kind of psoriasis, and we have to be on the lookout for dehydration in these patients and heart failure, because these patients are basically going into high output heart failure when presenting like this situation. And then there's the pustular psoriasis, which usually affects the palms and the base and the bases of the feet with small pustules. Ocular involvement, conjunctivitis in about 20% of the patients. And then in about 70% of the patients, they can have iritis. The most common presentation ocular that we see in the form of iritis is bilateral chronic posterior uveitis. Uveitis may present insidiously, where the patient does not complain of any vision changes, and slowly and gradually they lose vision, or acute symptoms where they have visual impairment. A simple way to assess them is if the patient has painful red eye with blurred vision and has a history of psoriasis, that can be of significant concern, and it's most common in females. And then dactylitis, which we oftentimes term as sausage finger, is essentially tenosynovitis of the and peritendinosis of the tendons and soft tissue edema of the tendons of the hands and the fingers. And swelling occurs of the synovial sheath, often prevents flexion of the fingers. And swelling is usually between not the joints itself, but it's usually between the two joints. So you will see swelling between the DIP and the MCP, or MCP and all the way to the DIP joint. So you will see swelling within the finger itself and not just the joint. Okay, so that's one thing that sort of you can use to differentiate between a joint swelling versus dactylitis. It's usually asymmetrical. usually will involve one or two fingers. So if a patient tells you all my fingers are swollen, that's something else. That's usually not dactylitis. It can be acute or chronic. Uh, Differentials include tuberculosis. Of course, in America, that's not much of a concern because it's not much of an endemic here. And and then another hallmark of the disease is enthesitis. Enthesitis is where insertion of tendons and ligaments or fascia to the bone. And common spots for swelling of these enthesitis is the Achilles tendon, the base of the elbows. And oftentimes that is where the patient will have pain. So interestingly, the lower back pain is also a form of enthesitis. Essentially, that's where the swelling occurs. Uh, uh, but if the patient reports heel pain, elbow pain, especially on tenderness, that should be of concern because that could potentially be psoriasis progressing towards psoriatic arthritis. Now, this is a rare form of psoriatic arthritis, which is arthritis mutilans. It usually occurs in about 5% of the patients. And essentially, what happens is they have erosions of the DIP and the distal part of their fingers. And that's a pretty aggressive disease. Uh, Lab findings, there's no specific lab test which you can use to diagnose psoriatic arthritis as such, but a background general elevation in ESR CRP can be of concern. Uh, Having a negative rheumatoid factor is also important because remember back in the day, it used to be considered a form of rheumatoid arthritis, but then they realized it's not really rheumatoid arthritis. So, getting a rheumatoid factor and ruling out rheumatoid arthritis is important. Uric acid levels is important, especially uh, patients who have really widespread psoriasis. They have a high skin turnover, and that can precipitate uric acid levels to go up or and gout flares in these patients. So it's good to have a good idea about the uric acid levels. And then, of course, if you happen to tap the joint, you'll see increased cell count and increased polymorphic nuclear leukocytes in their synovial fluid. Radiographic findings, there's the most commonly tested in the boards is usually the pencil in a cup, where they basically show you an X-ray, and what they're looking for is a pencil in a cup deformity, and that happens due to the distal erosion of the interpharyngeal bone. And then there's acroosseolysis, which is DIP erosion. Uh, and then another one is asymmetrical bulky syndesmophytes, which oftentimes is seen on the X-ray of the lumbar or thoracic spine, and we see big, chunky, jug-like osteophytes on the in between the two vertebrae. Now, the difference between these osteophytes and ankylosing spondylitis versus psoriatic arthritis is ankylosing spondylitis will have thin, fine osteophytes, whereas psoriatic arthritis will have big, chunky osteophytes. Diagnostic criteria based on Casper criteria in 2006, you have to have a score of 3 and plus, which brings the specificity and sensitivity up to 99% specificity and 92% sensitivity. Having history or current uh, diagnosis of psoriasis gives you a score of 2. Family history gives you add up score of 1. And then, as I mentioned, nail dystrophy is oftentimes seen in about 90% of the patients. So that can contribute to the scoring as well. Having a negative rheumatoid factor rules out rheumatoid arthritis. And then dactylitis radiographic findings add up to the diagnosis. Now, psoriatic arthritis versus seronegative spondyloarthropathies. Now, it's a big mouthful. What I'm trying to get to is patients have other spondyloarthropathies presenting with psoriatic arthritis as well. For example, they'll have sacroiliitis, which is oftentimes seen in patients with ankylosing spondylitis. They'll have syndesmophytes, which is also seen in ankylosing spondylitis. They'll have uveitis, which is oftentimes seen in ankylosing spondylitis. The difference is in psoriatic arthritis, it's usually chronic bilateral posterior uveitis, and in ankylosing spondylitis is usually acute unilateral anterior uveitis. Pre-treatment goals. So whenever we are prepping up the patient for treatment, the most important thing is getting the patients vaccinated for pneumonia, for shingles, influenza, so that they don't flare up. I've had so many patients where we start them on therapy and they end up having uh, uh, shingles after they were started on therapy. Of course, screening for tuberculosis and hepatitis before you start them on therapy. And basic education about immunosuppression therapy itself is really crucial. And I think many of the physicians also sort of have a different understanding of what immunosuppression are we talking about. And I'll go into a little bit more detail later, but we're not obliterating their immune system. We're just bringing their immune system to a level which is a little bit more functional. But they're still predisposed to infections, opportunistic infections, and all. So for mild disease, we usually treat with NSAIDs. I usually prefer celecoxib because it's a COX-2 inhibitor, doesn't cause that many side effects, GI side effects. And then with moderate disease, we can do other synthetic DMARDs, for example, methotrexate, leflunomide, sulfasalazine, or Tesla. For severe disease with polyarticular involvement, if the patient has erosive disease, we can go do methotrexate or other biological therapies. Now, methotrexate, I'll just briefly touch base with these medicines. You really don't have to go through the whole slide. Um, we usually have a max dose of about 25. We give it once a week. Oftentimes, patients complain of hair loss, oral ulcers, and we usually give it with folic acid to prevent those side effects. I usually monitor liver functions every 3 months, so to prevent hepatotoxicity. Leflunomide is if we cannot tolerate methotrexate, we can often use leflunomide. It's not as effective for psoriasis, mostly effective for arthritis part. Sulfasalazine can also be used, but oftentimes has significant GI side effects, and rarely can cause leukopenia or neutropenia. Um, A Tesla, which is the phosphodiesterase 4 inhibitor, can also be used for management of psoriatic arthritis. It's usually reserved for mild to moderate disease in patients who do not want or who are not comfortable with immunosuppression. I usually keep it for patients who have more predominant psoriasis and extra articular presentation rather than uh, rather than arthritic heavy presentation. Um, One thing to keep in mind is it can sort of precipitate depression in some patients. Uh, Very common side effect is loose stools. Uh, so coming back to this slide, because this is important when we're discussing about biological therapy. So if this is our immune system, essentially we have different legs of immune system which we can sort of suppress to see if the patient has any response to the disease. Most common is TNF, which is Enbrel, Humira, Cimzia, or Remicade. We can also use anti-CD20, which is rituximab. We could use JAK2 inhibitors. We can use IL-17, IL-23 inhibitors. So, I mean, just to give you a basic sense that we don't have to completely obliterate the immune system. We're only picking up one leg of the immune system and sort of suppressing it and seeing how the patient responds. And if that suppression doesn't work, then we move on to the next part of the immune system, sort of suppress it and see how the patient responds. Anti-TNF is the most common therapy which is deployed, which includes infliximab, Humira, etanercept, Cimzia. Patients usually we avoid it in patients who have multiple sclerosis or have a first degree of patients with multiple sclerosis. Um, and Usually, we try two different types of anti-TNF therapy before we proceed to a different class of immunosuppression. IL-17 is another one of mention is Cosentyx. Bimzelx is the new one which came across. We usually can't use this in patients who have IBD, but in patients who have IBD, we sort of prefer Skyrizi, ustekinumab, and Tremfya, because they have better coverage for IBD as well. Tofacitinib, upadacitinib is another medication. These are the good thing about these medications is they are JAK inhibitors, but they basically are oral therapies, so patient doesn't have to inject themselves. Uh, they can be associated with GI perforations, so we try to prevent if the patient has had a history of diverticulitis or if the patient has history of cardiac disease, because it can cause elevated cholesterol and high risk of thrombosis. So, in summary, psoriatic arthritis is a is a musculoskeletal disease which mostly proceeds with psoriasis, follows up with involvement of inflammatory arthritis, which can be both axial as well as peripheral. And extra-articular findings of the psoriatic arthritis is, of course, psoriasis itself, and then most common is nail dystrophy, dactylitis, ocular manifestation, and enthesitis. Early identification is really important because 1 out of 5 patients with psoriasis will eventually have or will progress into psoriatic arthritis. So when we see patients in our clinic who have psoriasis and are seeing dermatology and come to us with complaints of knee pain or joint pains or nail changes, that could be a trigger towards early diagnosis and treatment in these patients. And treatment strategy that we employ is we start with NSAIDs, we go to DMARDs like methotrexate, and then we progress to biological therapy depending on how severe the disease is and what their workup has revealed. Thank you so much. Questions?